Testosterone is the hormone of desire. It triggers receptors in the brain and in the genitals, both. There are receptors for testosterone in your brain, which trigger neurotransmitters, which lead down or trigger or turn on the pathways of desire in the brain. That's well understood in the research. Some women are sensitive to that change, and so there are opportunities to think about that. In our field, there's off-label use of transdermal testosterone that's based on some evidence.
Welcome back to the Rena Malik MD podcast. I'm your host, Dr. Rena Malik, urologist and pelvic surgeon. Today, our guest is Dr. Sharon Parish. Dr. Parish is a renowned sexual medicine expert, general internist, and professor at Weill Cornell Medical College. She has a wealth of information about sexual medicine and has authored numerous publications, including several guidelines on sexual medicine for women. Today, we talk about perimenopause and menopause. What exactly happens? What sort of non-pharmacologic techniques can we do to combat symptoms associated with perimenopause and menopause, as well as when is hormone replacement therapy appropriate? And how long should you continue it for? We talk about the limitations of the data from the Women's Health Initiative, which has formed a lot of the population's belief on the safety of hormone replacement therapy and how that's evolving. We talk about how society views menopause and aging in women, and we talk about how breast cancer affects the use of hormones in women undergoing menopause. We talk about what bioidentical hormones are and where you can obtain those. Last but not least, we talk about sex drive in aging women and what you can do to combat decreased libido in women. Hope you enjoy it. Dr. Parish, thank you so much for joining us.
Oh, it's my honor and pleasure. I'm really looking forward to the opportunity to share some of this information.
Yeah, so let's start. We're going to talk today about perimenopause and menopause. But what I want to start about before we start talking about the science is, how do you think society views these transitions in life, whether it's women themselves or their partners or just as a whole?
This is evolving. I've noticed, and I'm sure you have too, in all forms of media, New York Times, LA Times, podcasts, Good Morning America, whatever, that there's a lot more attention toward this particular transition, perimenopause and menopause, and really trying to normalize some of the things that women have really felt even shame or kept in the closet. And, diverse topics like the impact is sort of more perimenopause or premenopause is the impact of contraception on sexual function, the role or the impact of menopause symptoms on workplace performance or productivity, like all kinds of variations in culture and ethnicity in menopause. I think we're seeing a lot more, which is either going to hopefully influence or it may reflect ideally, or either that or influence kind of how these things are seen. As we move forward.
I think it's really important. I think traditionally it's been seen as sort of like a nuisance almost, right? That maybe non-female people think is a nuisance or like an annoyance, and women sort of feel embarrassed that they're going through this. And thankfully that's sort of changing and evolving.
Yeah, I thought that the thing that was the nuisance thing that women had to hide before I really got into the field of menopause was pregnancy. Like if someone, for example, you think of these 1960s or 50s or as women became liberated, sitcoms or whatever, where, someone goes for a job interview and they take off their engagement ring because they're afraid they're going to be asked if they want to leave to have children and that, that big barrier of women having reproductive freedom and they didn't have to worry about that professionally was over. And as I got more into the field of menopause, I realized some of these things.
Yeah.
That it was symptoms were embarrassing to women. They hid it. But I think it touches on a broader issue of sensitivity and societal bias, which has to do with aging in women.
Absolutely.
And I realize I even have it myself. When I talk about professional development or the future, I'm kind of thinking of myself as a clock ticking, limited by my age or my, how people are going to see me, my youthfulness, even as a professional. And I know my colleagues have that feeling, whereas my male equivalents don't think about that at all.
Never.
As you hit midlife, you start to say, well, yeah, how many more decades do I have left? And as there's a discussion about which president, who's an octogenarian president should be president, I realize my own implicit bias about this. It would never be okay for a woman in her 80s.
And yes, it should be. It shouldn't be okay for, I think, either gender in their 80s, to be quite honest with you. But
that's a whole nother, I didn't mean to imply any political view on this or any opinion about age, but that it really touches on a much broader question of how women perceive themselves as they reach midlife. I mean, a midlife menopausal woman is not old. That's a young woman, right, who's like got so much time and energy ahead and so many, but it's a hormonal and a physiologic transition.
Yeah.
And which also often is paired with other transitions by sort of, I think it goes along with the reproductive life cycle, right?
Yeah, and it's inevitable.
Yeah.
And there's no exact synonymous time in men, right? There's not this abrupt cessation of hormones like there is in women that can have this huge impact.
I think it's more insidious, but I think that I'm more and more I'm hearing ideas like andropause. In men, it's thought to all be like a social phenomenon. Are they having a midlife crisis and do they need a younger version of what they had already in their relationship? And what's going to make them feel useful? But it's not. It's almost glorified, like time to get revive and rejuvenate. Whereas in women, you have to be explanatory. Like, oh, no, that's not happening to me, or hide symptoms, or demonstrate or prove that you're staying young.
Yeah.
And it's wrapped up in a much broader question. But at the most basic level, women do, I think we are removing some of the implicit and explicit biases in some of the areas of shame or embarrassment about just some of the physical and medical facts that go along with this time as we talk about menopause.
Yeah, so let's get into it. I think the thing that surprised me when I learned about this, and to be quite frank, I don't remember learning it in medical school, was that perimenopause can be up to 10 years before menopause, which can start as early as 45 and kind of go up, average is 51. So what are some symptoms that people start experiencing most commonly during the perimenopausal stage, and how can they sort of prepare or even realize that maybe they're going through perimenopause?
So I think there's a few different concepts of what constitutes perimenopause. At the most, I think the most limited view would be this whole idea of there's something for those of you that are like thinking about this who don't do medical stuff, is the straw criteria, right? It's a couple, and it's sort of roughly 7 years, 5 to 7-ish years. And it's the time when you're starting to have symptoms, but your menses are regular.
Right.
Then there's the time. So when you ask about what should you look for, maybe you notice it might not even be that your menses are irregular, but they're different. So let's start with that, even basic biological piece. They might be heavier or shorter or longer, or they'll start to notice variability in how they experience perimenstrual symptoms. It doesn't feel like the same as it had felt up until, before their mid or early 40s. And then things that you move more classically perimenopausal in that 1 or 2 years that straddles the time when menses start to either change or stop is the more conventional things like some what people call hot flushes or hot flashes, feeling sweatier at night, some irregular sleep that's disrupted by either vasomotor or other non-specific symptoms. Some women notice mood changes or irritability, or I'm not so sure about some of the other stuff like joint pain or bloating, or it's all a little bit hard to decide because people have symptoms and then they either attribute or misattribute them to what's menopause. And then you start to really notice the hallmark is really changes in the way the menstrual cycle occurs, or it plays out. Is it, more spread out? Is it heavier? Is it stopped for periods of time altogether? So I think those are the things that I tell people to look for. Now, is it important to know? Let's say I'm 42 and my cycle looks a little different, or maybe I feel a little bit different around my perimenstrual time. Is that important? Well, it depends. If it's interfering with your life or causing some difficulty in some way or another, it's nice to look for an explanation and then think, okay, what should I be doing differently? Should I be changing my contraception? Should I start to think about sort of the health-related issues that are important, like bone health, cardiovascular risk, et cetera? Why is that important for me to pay attention to?
Yeah. And I think that's the question. I mean, some people will kind of inflate these sort of atypical symptoms that sort of are multifactorial, like hair loss, weight gain, mood changes, musculoskeletal symptoms, which are very common. Recent studies showed 75% of women who are in menopause have musculoskeletal symptoms. But I wonder if that's, in general, that's probably also a function of age too, to some degree.
I mean, women in their 50s have musculoskeletal symptoms. So it gets a little more difficult to know or attribute. But what I kind of say to people is we're going to come up with the best plan to make you feel optimized. And I'm not sure hormone replacement therapy is the answer for your joint pain. Maybe it's weight loss and yoga and going to see, physical therapist. Like I have to look at the whole picture, right? Or it's a side effect of a medication, who knows, right? Like, so I'm a general internist that does, midlife women's health and sexual medicine. And I see people in consultation now, although I think we were chatting earlier, I used to have a more general medical practice. And I take a very kind of functional and practical approach to looking at like, okay, what is everything collectively that's bothering you? What do we know about what helps X, Y, and Z? And explanatory models for either specific symptoms or syndromes can be helpful to people. But I'm cautious not to like say, this is all menopause. Mm-hmm. Let's use this X, Y, or Z approach to hormone replacement. And there's a whole variety of approaches. And you'll feel better and see me next year. Like that's not going to do anybody any good because most things are multifactorial, right? Yeah. And like there's a lot of things that weigh in. I mean, I think the other thing is that there's things that happen to women around this time in their life that impact how people feel. So I hate to sound too, jargony, but they are also sandwiched, right? Like they have little kids are becoming college kids and there's financial responsibilities and they have aging parents and there are relationship transitions and decisions about where they want the career to go. And all of that impacts how people feel, how much sleep they get, how much fatigue how much time they have to exercise. So I think you have to kind of like, while there are like very specific things that we can do to help with menopausal symptoms, you have to tease it out a little bit.
So in that perimenopausal space and into menopause, which is defined as 12 months without a period, when do you consider starting hormone replacement therapy? Do you consider it as an adjunct if they're having some of these symptoms to what they're already experiencing, like to the yoga and to the other things? Or do you say, let's try the other things first? Or how do you determine?
My basic view on the role of menopausal hormone replacement or therapy or supplementation, there's a variety of terms that are used. The first thing to remember is that a perimenopausal to early menopausal woman who's feeling things isn't sick, right? Yeah. And I think if like you remember the listeners, if you don't remember anything else, you're not sick, and I know sometimes you don't feel well and it impacts your quality of life or your ability to do your job or be at your best with your family, or you're exhausted from not sleeping. And so therefore you may be impaired. It may be affecting your quality of life. It may have impact that's important to intervene with, right? And the goal is really to do something to help you that's going to benefit you the most and give you the least amount of harm, right? So one of the basic principles of using menopausal hormones is that you want to use what's available that's going to be the least harmful to the individual and manage the symptoms optimally, but not more. And not for these, there's much controversy about treating asymptomatic people or people for prevention of disease. But if you limit the discussion to like you're dealing with symptoms, my sense of when I would use menopausal hormone therapy is when somebody has certainly impactful and disabling vasomotor symptoms. So that means like, that's my first criteria. In the daytime, they're having hot flashes. And should we talk a little bit about like what, so people know how to identify what's a hot flash? And it's sometimes it's missed by people and by clinicians because it has a variety of different like faces, right? So typically someone will suddenly feel a sense of warmth, heat in their, what you see on TV.
Yeah, sweaty, hot.
They sweat. They want to like, and women describe this to me every day. They feel suddenly very warm. They may feel a sense of rising heat in like the chest, arms, or face. It's sometimes associated with redness and an actual feeling of flushing. And that's the term flashes or flushing. People often feel sweaty, and sometimes women will say, I just like want to tear my clothes off. I'm in the middle of a lecture and I feel like I have to tear my shirt off. Or they, want an ice pack or go to the refrigerator. I mean, that's the most extreme version. But I also find people kind of have a variance and milder descriptions. Like, I just suddenly feel like agitated or warm or like irritated or racy or anxious. And my differential is always like, there are also a lot of reasons for women and people to be anxious, right? And having anxiety-like or panic-like, symptoms. So sometimes it takes on that form, and that's a clinical interview to discuss it. And that's not to say, for anyone listening to this, that every time you feel suddenly anxious that you're having a hot flash. But if it's happening every 2 hours, there'll be people say every like 8 to 10 times a day. And generally they can last anywhere from 50 to 30 minutes to up to an hour. They're generally not like momentary, and they're generally not prolonged all day long, right? Like continuously. and it's happening in episodes and it has some of these features, you may be having hot flashes. So that there are things you can do that aren't menopause, hormone replacement or menopausal hormone therapy. At night, people get similar symptoms. They're called night sweats. And the problem there is that if they're happening every few hours, even up to like every 1 to 2 hours, you have this happen, it wakes you up, you become drenched, the sheets are wet. Sometimes it's not that extreme, and often there are variants. People are up for a while, and then because they're worried from anything from A to Z, or that they're now awakened and they're not going to be able to fall back asleep, it can be very disruptive to sleep. I don't always find that people who have symptoms in the day have night symptoms, and people who have symptoms in the night have day symptoms, but sometimes people have them in both situations. I hear more commonly that people have like, it bothers me during the day, but not so much at night, or once in a while at night. Does that influence my decision? It's really all about having a conversation with the woman and dialogue about how much this is interfering, how impactful it is, how much it's like at the most basic level, sleep and ability to perform their duties, whether it's work at home or professional work or other activities. And then, there are some non-pharmacologic approaches that you can try. I don't know if you want to talk about those as well.
Yeah, we could talk about those.
But, generally I try to start with the other things. And if it seems like they don't work, then we move to hormones. And this is in the basic principle of start with things that are going to be less harmful. And then, it's not that they're harmful, but that have risks and benefits.
Right. We
can discuss that afterwards. But those things are kind of what you think. Stay cool, dress in layers, wear breathable material. At night, there's lores or legends like grab frozen, have lots of frozen peas in your freezer. I happen to like frozen peas, and I learned it a long time ago because people can wrap it around things. And then a favorite colleague of mine said, just have them throw it on the floor and cook them for dinner the next night. By then they're defrosted. So. But
we love frozen peas in urology too. They're great for scrotal.
You could do edamame. You could do corn. Pick your frozen small item. Fans, avoiding hot. There's some value to like avoiding alcohol and vasodilating beverages, hot beverages or alcohol in the evening. It works a little.
Yeah.
You may have the same experience. And there is some non-hormonal supplements. There's something called black cohosh. The German government has standardized it in a product called Remifenin. And there's a dose you can buy it at a standard health food store. I'm not promoting it, but it's available if people don't want to take hormonal therapy.
It has some reasonable data.
And the data is not bad. And I've had some people say it's helpful. There's some other companies that have some other products that are marketed for this. And it can be helpful. Relazin is another example from a company called Hello Bonafide. I'm not promoting any products, but just so people get an idea.
Yeah.
They're supplements. They often have a combination of herbs and minerals or other like chemical constitutions, just so to speak. I think if someone wants to, first behavioral, there's been some work looking at things, in fact, like yoga, paced breathing, relaxation techniques, and the data's, modest at best. When I said it before, I meant like if someone's stiff a lot from sitting all day at their job and they think they're in menopause, and I say, how much do you move? I'm tight all the time. I might recommend
yoga.
Yeah. But if someone's having hot flashes and can't sleep at night, I don't tell them that yoga is going to fix it.
Yeah.
If they're getting very muscle tightness and they feel it'll be a relaxing experience. So I explain all these things to someone, and then I might, if they will like a non-pharmacologic approach that's a supplement, I offer that as an option. If someone's really disabled, I say, look, we can try all of this simultaneously, but you probably will find that to get the quickest relief by going on menopausal hormone therapy. And so, that's sort of how I think through. And that now called the Menopause Society, used to be called the North American Menopause Society, which has the most kind of widely disseminated guidelines on this, and a relatively new position statement that anyone can look at on their website, really says still to use the lowest dose for the shortest amount of time to control the person's symptoms and improve quality of life. There's some variation like that is the wording.
Yeah.
Now, like, what's the shortest amount of time? You don't know till you stop. So generally people say, like, give it a trial for 6 to 12 months and then taper.
Yeah.
And then continue. And sometimes, and then there's other parts to that position statement which say, like, go for some years, but don't go over usually
10 years or
over
something.
10 years or up to 60, depending on how you look at it. And then you should stop. So, like, I don't give people that answer till we see how it goes.
Yeah, if they're doing great on hormone therapy, I think it's safe to continue, particularly if you started early, because there's a lot of data on the benefits of hormonal replacement therapy for bone health and even some data on cardiovascular health and mortality when patients start it early.
This is a whole another area where we can discuss, like, what are the benefits and the risks? So certainly the benefits are, there's nothing, so there are other pharmaceuticals, I don't know, we could also get into that, we can mention those, that have been studied and may help with hot flashes. And these are particularly useful or offered to women who either don't want to take hormones or it's not recommended because they have a hormonally dependent cancer or something. So the serotonin reuptake inhibitor antidepressant classes and the serotonin reuptake inhibitor combined serotonin norepinephrine reuptake. Some of the anti-epileptic drugs that are used, like gabapentin, used for atypical purposes like this. Clonidine, antihypertensive, has even been studied. Probably the best option if you're not going to go to a hormone is to use an SSRI antidepressant. In fact, there's one, paroxetine, that's actually made in a dose that's marketed and been researched and marketed for hot flashes. Those are options. But, generally, it's hard to say, like, the shortest period of time because people feel good. Yeah. And so if they feel good, then you don't know what's going to happen if you peel it away. And so then it's a dialogue with the person, the patient. This may have benefits for you to use it for, say, 10 years until you're 60. For other things like bone health, cardiovascular risk, disease prevention, that's a different conversation. But if your symptoms are now controlled, generally perimenopausal symptoms are the most severe. Let's go back to the time frame for a little so people aren't confused. So I think, yes, it can be quite early, even a decade before you actually stop menstruating. And menopause, you don't know you're in menopause till you stop for a year. Yeah. So sometimes you have to wait and see. But let's say it's 5 to 7 years, based on what I said. The few years where you start to notice menstrual changes and some hot flashes, then the menses change, then they're over. And you're done, but you're still having symptoms. Say that's another 1 to 2 years. And those symptoms could be these hot flashes, these vasomotor symptoms and night sweats. So let's say you start and they've already had them for a year or two. I say, like, this is probably going to go on for another couple of years. Let's not even stop until then. But if someone's like, it's been going on for 5 years, I finally can't take it. I'm like, well, I'm glad you made it here now. I might give it a year or two or a year or 6 months even, and then have them taper down a little. But then at that point, if that's all they want to do, the discussion is only about symptom control. But if they and I want to engage in the idea of longer treatment, because of, it's good to start early. I completely agree with you that this may protect bone density. It may improve cardiovascular profiles as they enter their 60s. Then we start to say, well, okay, now we're going to talk about continuing, even though your symptoms, you might be past the peak and they might be pretty mild if we tapered this off. That said, I've tapered women in their 60s and 70s who are like, I don't care.
I want to
stay on it. And that's a whole nother topic. Because they like the way they feel in a variety of ways. And they do get hot flashes when you taper. Yeah. And some women can go on for years because when you withdraw it, if you don't do it and you don't taper it, people are going to have symptoms.
And so off the guidelines, because the guidelines recommend what they recommend, but what are your thoughts on continuing, or maybe continuing at a lower dose perhaps, into past your 60s or even up till you're 60? What are your thoughts on that?
Well, I live in New York, and my own gynecologist, I won't say who it is, to protect her privacy, I ask her what her opinion is, and she says, well, I tell my patients, and there's all variations of this, but until 3 days before they die. And so I was asking her, why 3 days? And she goes, it's just a point,
Yeah, no.
So I mean, there are some theories like that. I don't know. And and this is a well-regarded gynecologist. So there are some in our field, even who are highly endorsing guidelines, and this is one of them. So I hear that point, and I have to think how I'm integrating that my own advice for me and my own decisions. But I think the point of this is that despite the guidelines, there are many experts and many in the field who feel there are some longer term benefits, and the available data that we have may have had it had to do with the product we use, the women that were studied, the age in which women entered the WHI. This is the most well-known trial. Yes. If you start hormone therapy at 70, yes, it may be riskier to continue to 80 or 85 or 83.
Yeah.
But we don't have the trial with that type of detail where someone only started in their 50s and went for 25 years.
Yeah. So that's sort of the limitations of the WHI, which they had an older population with more comorbidities. They used formulations of estrogen and progesterone, which are no longer commonly used. And so I think the data is, again, sort of skewed into that patient population, not ones who start in their 50s.
Right. So the people in that study who started in there, as we both know, and I think I'm glad we're talking about it, who started in their 50s in the first decade, tended to have good outcomes. You know, they didn't have, well, we're just talking about preventing, so their symptoms were well controlled, the ones we're discussing. They seem to have, and they used higher doses necessarily, used oral therapies, which is different than what we're doing now, and we can get into that if you like. But they seemed to do well in terms of adverse events like strokes and cardiovascular effects and so forth. And it seems to be that, yes, you may offer, in fact, a protective effect to the two big outcomes when you're talking about disease prevention have to do with bone density, prevention of osteoporotic fracture, and cardiovascular risk. And, future cardiovascular ischemic events, whether they're ischemia, et cetera, the whole spectrum. So we don't have data like starting in their 70s. I'm not a big fan. So let me answer your question in a few ways. I definitely am happy to work with someone to do sort of what the guidelines say, which is it's sort of fine if someone wants to go beyond symptom control for the first decade because the risk is relatively low based on what we do know of causing an adverse event, and it probably helps them in a number of ways. Once we get past that, I'm fine working with individual women to understand their individual risk and their goals for ongoing therapy. So for some women, it's just like every time they taper, they feel incredibly symptomatic and they're just not willing to do it. And I'm not worried enough in that particular woman to say, look, I can't prescribe this anymore.
Right.
Or they feel like, well, yes, I think I would like to talk about how this, because it does protect bone density.
Yeah.
Particularly the estrogen component stabilizes bone density loss. It doesn't reverse, osteoporosis or prevent fracture probably, but it stabilizes, we can get it, that's another data, but it stabilizes bone density. And there may be some evidence suggesting that lower doses are fine for that purpose, right?
Right.
So it's easier when someone doesn't have a uterus, right? Because then we also haven't talked about that much. Most of the benefit you get, by the way, and it's very important for the audience to hear this, has to do with, when we talk about hormone therapy, we should make sure we're clear. It means some form of estrogen or estradiol and some form of progestin, except for one product, which is an oral product called Duave, which is now available again. And the purpose of the estrogen is to work at these issues, prevent vasomotor symptoms, and the estrogen family seems to be the element in hormone therapy that protects your bones and your heart.
Right.
When you're talking about early prevention. You have to add a progestin or something to protect the uterus, because giving unopposed estrogen can lead to endometrial hyperplasia or thickening of the lining of the uterus, which can potentially lead to endometrial cancer. So that's required. I think every guideline, every clinician, feels that's a lot responsible clinician feels that's important. And there are a number of ways to do that too. There's not much else. I get this asked a lot. Like they hear like, oh, my doctor said I should be on progestin, or this person I heard on this X, Y, or Z should be on progestin because it's good for women's, brain health or well-being or, overall physical support for menopause. And that's very murky. So if someone doesn't need a progestin because they don't have a uterus, I'm not inclined to give it to them. Yeah. That's maybe you have a different view on that.
I only prescribe it when someone has a uterus.
And so it protects against endometrial hyperplasia and cancer and uncontrolled bleeding. The problem is that the progestin may be attributable to some of the problems that people worry about with long-term use, such as we haven't talked about the breast yet, right? So does it increase breast density, increase risk for atypia, increase the risk for breast carcinoma in women? And again, that has to be interpreted in the landscape of the preparation and what we know from the WHI, which is only synthetic oral medroxyprogesterone acetate. Factoring in other breast cancer risk factors, which weren't really done in that study, right?
Yeah.
Like that would be a much more elegant way to determine for that woman. And that's those that I know who do this longer term of progestin look at more complex modeling, right? Yeah. Like first you start with like, okay, you're 60, you've been on this for, or let's say several years, your symptoms are better. Probably if we tapered, they would be better because you're past your peak of like, the reason people have symptoms is that the ovarian hormones are all over the place as you peter out and stop making eggs.
Yes.
As the senescence of the egg production happens. It's just a thing. We're not dying. We're just changing. But because the levels are all over the place, people have lots of symptoms. It interacts with all these brain centers that are responsible for heat and sweating and all that.
And there's receptors all over the body.
And that's why, but as that levels off and you reach like an equilibrium, people generally when you taper have fewer symptoms. Yeah. So when I look at that, and if they need a progestin, then it starts to be a discussion. So there's not one answer.
Right.
You can go lower on the estrogen dose, but there's no good data that you can go lower on the progestin dose, right? So then one of the big questions for me with them is breast cancer risk. So that's where I use breast cancer risk modeling to help make individualized decisions. And that's like a whole nother topic. But some of the key things are family history of a first degree female relative. There's data like body weight, alcohol use, breast density, and very dense breasts. And then what are they willing to go through in terms of breast cancer screening and evaluation? So if they're going to get an MRI every year, they may end up with lots of some biopsies. Not everyone with MRIs gets biopsies. I don't want to give that bias.
Yeah, no, nowadays they're doing it for screening purposes too.
But you end up with more detection, and those have benefits and risks as well. Right. So that's one of the things that figures in is if they need a progestin. If they don't, then it's just about the estrogen, and it becomes a little easier. Like, how do we want to deal with this in terms of symptom management? When are you ready to try a taper? Do you want to continue this for some of the potential ways that you feel better or may have disease prevention benefits, although that's, again, controversial? Would a low dose do enough? Like, how much do you need to protect your bones? We don't have good long-term studies on that because after the WHI, nobody was willing to invest in these kinds of study questions.
Yes,
right?
yes. And that's a shame, right? Because I think we would know a lot more today. And hopefully now we will be doing more research in this area. But that certainly set people back quite a bit, I think, in terms of interpreting those findings appropriately for the younger female with less risk.
The good news for people, as we talk about this for people listening, is that there is a dedicated menopause society. We mentioned it offhandedly. Right. It used to be called the North American Menopause Society, but they changed the name recently to just be called the Menopause Society. And it's a great website if women want to find a resource. I often recommend.
Yeah, and find a provider near you.
Right. There's a Find the Provider site. There is a section for patients and for professionals as well. You can become a member and get even more access. But some of their materials, like position statements, are available in general. You don't have to be a member. But those leading groups and sexual medicine societies and subgroups in like gynecologic and endocrine societies are doing research on different preparations, different doses, different modes of delivery, and looking at some of these shorter and long-term questions. It's not like, that was the last study.
Oh, no. I mean, meaning that I think it was set back a little bit.
I know you knew. I know, of course you meant that, but I just want to make everyone knows that we're being clear that the field is moving forward.
Yes.
And I have a lot of optimism that some of these questions will be, I think this is an area where it's not stuck.
Oh, I agree with you. And I think I agree.
Yeah.
I wanted to ask about if someone has had a hysterectomy or they have an IUD and they're not menstruating because of the IUD or whatever sort of hormonal abnormality for which reason they're not having a menses, how will they know? Is it just symptoms?
Yeah. So I just saw a patient who's like, it sounded like that famous song, How Will I Know? How will I know? Yeah. And I feel like I hear that a lot. Like, how do I know if I'm in menopause, especially if they're having, so when you put in, for those of you who don't have an IUD, when you put an IUD in someone, I think we tend to see it more in who women get an IUD after they finish their last child and they're in their 40s. Mm-hmm. Menses can become light, or they can become less frequent and scant, or even stop altogether. It's not unusual. I'll hear someone say, like, I had a few for a while and then they stopped altogether. And that's particularly only with the hormone or progestin containing IUD. Mm-hmm. Like the brand is the Mirena. Most women at that age have the higher dose Mirena. At that point, it's really symptoms. So the symptoms are going to be more classic because you don't see the bleeding changes. Mm-hmm. Occasionally someone will say, though, that like they'll have like changes in just like the perimenstrual symptoms that aren't around bleeding, and it feels different. And sometimes I look for those clues, like the bloating, or some women get changes in their bowels, or they get back pain, and it's like I'm not noticing that anymore, even though they had their IUD when they were having some perimenstrual symptoms. Yeah, we don't accuse perimenopausal and perimenstrual, but that's one thing. But mostly I look for like traditional symptoms. And then like a patient I saw the other day who's like, my mother had a really late menopause. I'm 55. I have contraception in, so I'm not really worried. Is there any reason I need to know if I'm in menopause? Yeah. If her symptoms were relatively mild. And I was like, No, not really. Because she didn't come to me for that. But
Right.
she asked me that question.
Right.
Right? So I said, like, when you take your IUD out, which she had a few more years for it, and if and then you want to use hormones, then we would be having to think about where you were in your transition and try to figure this out better.
Yeah.
She had come to me for questions about sexual function that were sort of, to some, I mean, they're related. That's kind
Yes.
of, like, we look at how sexual function is related. We haven't even really talked about that. We're talking about the more typical symptoms. It's important that we do talk about another, like, bucket of more traditionally postmenopausal symptoms, but it can happen in the perimenopause, which is the genital urinary
Yes,
symptoms.
we're
And
gonna get there.
I sort of left those out because I think of those as more like early postmenopausal and postmenopausal, but not necessarily. But what I look for, so in that woman, if she said to me, like, I was doing fine and now, like, I can't sleep at night, or I feel irritable, I look for what, like, subclinical stuff too. Like I said, like feeling, there's times when, like, someone, like, my doctor thinks I'm having panic attacks, and like I said earlier, and I'm like, those aren't panic attacks. You're having hot flashes. And again, don't think every time you feel anxious that you're having a hot flash, but that
It could be.
It could be.
I guess. Yeah.
So I look for those symptoms, and then I would determine whether it would be helpful. Now, the IUD is a bit of a discussion, whether a progestin IUD is sufficient protection if you do decide to use menopausal estrogen therapy.
Mm-hmm.
And many feel it's fine.
Yeah.
And I'm impressed by it being a safe and adequate way to do it. I'm not a gynecologist, so I don't put them in. But if someone asks me, along the way, I do prescribe hormones. If that would serve as their progestin, I feel comfortable with it.
Yeah,
Especially
same
if the
here.
gynecologist does.
Yeah. When was the last time a doctor spent an hour with you and truly focused on your goals? And when was the last time you left feeling like you really understood what was going on with your body and had a clear plan of what was going to happen next? At my practice, Rena Malik, MD, I aim to do just that. I specialize in sexual dysfunction, bladder health, hormone health, and pelvic pain for all people. And I want to revolutionize how we take care of patients. I want to really get to know each and every one of you. That's why at my practice, when you come to see me, I'm 100% present with you for an entire hour. And after you leave, if you forgot to ask me something or need clarification on something we talked about, don't worry. I'll respond to your issues and questions quickly through our secure messaging portal without any additional costs. Just go to www.renamalikmd.com/appointments and schedule your visit today. We see patients in Irvine and Beverly Hills, California, and virtually for patients from California, Florida, Illinois, Maryland, New York, New Jersey, and Virginia. If you aren't located in these states, consider making an educational visit where we can talk about your conditions generally, but I can't diagnose or treat you. I can't wait to see you. I want to talk about blood work, because I think people come in asking for blood work and wanting to know, I actually had a patient come to me with like her whole cycle mapped out with like and I think it leads to a lot of anxiety, but do you think it's necessary or valuable?
As part of the workup for menopausal symptoms.
Or perimenopause, or if they're coming with symptoms and they're wondering if adding hormone therapy will be beneficial.
So usually it's like, do I need blood work to figure out if I'm starting perimenopause or in menopause? Yeah. And then will it help you or help me to manage my symptoms by knowing the results of this blood test? So I think the place where it is helpful is if someone's relatively young and you're a little confused about either the bucket of some of the symptoms we're talking about, like anxiety versus hot flashes, not sleeping, and irregular bleeding. So if someone's in their 30s or even early 40s and we want to decide, there's a brain pituitary hormone I think, of course, you know what I'm going to say is the FSH level. Yeah. So if someone's 32 and their menses are erratic, and I don't have another good explanation, that's a different discussion and workup, I might include the pituitary hormone called FSH that interacts and regulates with the ovulatory cycle in that situation. If someone is 48 and having hot flashes and asks me if there's any value in testing either their estrogen level or this hormone FSH, or it wouldn't alter what I do. Because one, it's really, again, about symptom management mostly in that situation. So even if their FSH doesn't quite reach the threshold or it's sky high, I'm going to go more by the symptoms. Yeah. And two, it can be all over the place because women are ovulating intermittently. So that's part of the reason you get both the hot flashes, like I mentioned earlier, and the irregular bleeding, is because some months your ovary makes eggs, and it releases them and makes fully ovulates. Other months it makes the egg but doesn't ovulate. Other months it doesn't do anything. I said cessate, but it's in these times it's more like stutter.
Yeah.
It stops, it starts, it does what it wants. It's very temperamental.
Yeah, so you can even have if you were to get your hormones checked, I mean, people have been talking about this on social media, like estrogen dominance can occur during perimenopause because at some points you may have high estrogen because you may have had 2 back-to-back ovulations because of the way the phases of the menstrual cycle change. And that doesn't mean that you're not having symptoms, I think, really.
Right. So, I mean, you might have 2 months where so there's 2 phases to the menstrual cycle where you're in just the first phase, what's called the follicular phase, where you make the egg and it makes lots of estrogen, but you don't actually ovulate and release the egg. So lots of estrogen builds up. Mm-hmm. Then you might do that for 2 months. And then you have a month where you do ovulate and then there's progestin thrown in and you have a very heavy bleed. And even though the reason you're bleeding so heavy is because of this so-called estrogen dominance, all of that, it's fine. But the blood level at any one moment in time won't help that much, right? Because it could be all over the place. And the next month, like I said, though, you might not have either a follicular or an ovulatory event, and it'll be very low. But then the person's like, well, but I just bled for 10 days, or I'm having regular periods every other month, and then you check and it's 400. Yeah. So that it doesn't help me. It's not that informative, and most people don't use it for diagnostic or therapeutic or management purposes. I think with some of the other approaches that in clinics and places, like they try to twiddle with people's formulas, especially if you're using compounded products, which we don't generally recommend because we have such good FDA-approved bioidentical products, then those levels are followed. The category I absolutely don't agree with, and I think most of us in the field who are working with guidance and guidelines, things like saliva testing, urine testing, hair follicle or hair shaft analysis or whatever, it's just not very good systemized data that really helps us understand how to use that and treat people safely and effectively. There's some blood tests that sometimes are helpful. There's other problems that happen to women in their 30s, 40s, and 50s, like thyroid disease, right? Yep. For example, connective tissue disease even. So some person might be having my joints hurt and they're swollen and I think I'm in menopause, and I'm like, maybe we're dealing with a rheumatologic issue. So sometimes as an internist, I'm thinking systems-wise, there are other blood tests I might do. Yeah. But the actual hormones that are responsible for the variability in the menstrual cycle and some of these other fluctuations, testing them during the perimenopause is not that informative. And again, it doesn't guide that much.
And it can get you a little anxious.
Right. And people see all kinds of numbers. But if someone is 38 and we get an FSH and it's high, it'll help me. Yeah. I mean, one thing we do want to do, and I think you implied this to some extent earlier, and I know we would definitely talk about this if we got to it, is what to do with someone who is quite young, who clearly is having an early perimenopause or menopause, either based on symptoms or we do in fact decide to check some of these hormones because we want to see. They definitely benefit from, then it's, from, I feel, and I think many do, from getting hormones at least until the time of their natural menopause. Yeah. Because it does, that's where the early intervention does have an effect.
Or surgical menopause.
Right. So this comes up a lot in women who, get their breasts or their uterus removed or ovaries because of all these, they have genetic risk or family history or the whole BRCA syndrome. And many feel, including me and those that review the guidelines, there are guidelines on this, that giving women hormones back after they've had susceptible organs removed because of genetic risk is very important for protecting bones and cardiovascular risk and cognitive function and well-being and skin and all that. And that if they don't get that, from my opinion would be, that's my advice based on everything I'm reading in data and guidelines. If they're not getting that from the clinician they're seeing, that they should seek some other input or other opinions. Yeah. Because there are many experts who would feel they should get that and benefit.
I agree. And and if you guys want to deep dive into the literature about estrogen, I've actually made a whole podcast about how our bodies use estrogen, what the data is, and because we won't have time to get through all of that here today. Of course, so check that out because you can learn a lot more about it. And so let's get to sex because I want to make sure we talk about sex.
My favorite topic.
Yes, your favorite topic. Yes. So sex changes, libido changes for a lot of people, orgasmic function can change, lubrication, arousal can change. So let's talk about it.
I mentioned at the beginning, I have a consultative practice in menopause and sexual health, and I do see some men too, but primarily it's focused on midlife women. The first question is like, what's the interrelationship between what we've already been talking about and sexual function? And I will tell you that sexual function and sexual health is important to women of all ages, right? And I think it gets the most attention sort of.
And to everybody, to your partners, to
well, people of all, we're talking about cisgender women, I think, in this podcast today, but people of all genders and people of all ages, sexual health and sexual function is an important part of well-being, quality of life. Even the WHO is endorsing the importance of sexual pleasure and well-being and overall well-being, and that it's a right. And, not a privilege, but it's a basic human right.
Yeah.
And it could not just the freedom from coercion or misuse or abuse, but also the right to sexual well-being and sexual pleasure and sexual happiness. I mean, some variation on that is of it. And so we like it, that's also, talk about taboo. That's much worse than menopause,
Yeah.
Like a person coming to your, to public, to your office or somewhere and saying like, I'm having a sexual problem, and given all the other things that I'm responsible and I'm supposed to be doing, that I'm going to spend time, money, effort, and energy figuring this out, that's a big barrier.
Yeah.
And if we can start to break that barrier, right? And sometimes it's all mushed together for women. Like, I'm having hot flash night sweats, I have no libido, I have vaginal dryness, it hurts when I have sex. Like, am I in menopause?
Yeah.
So some of that is attributable.
Yeah.
Like it's the same story, right?
Right.
Like,
Estrogen decreases in the vaginal tissues and causes a whole host of changes, some of which can include dryness, thinness, lack of lubrication.
I see that as like the easier piece to this.
Yeah.
So when estrogen is the hormone of, cushion and lubrication in the genital urinary tissue. So the terminology is important for women, and I know you're a urologist, so I know you buy into that idea. So there's the inside of your vagina. It's like the deep inside vagina. There's the inner outer vagina, which is the closer part, but when you get inside the opening or the introitus, there's what's called the vestibule, which is the entrance. It's the rim it's flanked by the labia minora and the labia majora, and the clitoral hood and the clitoris and the urethra's in there. The clitoris and the urethra are together. The urethral meatus comes out through the clitoris, and all of those tissues are important, and they're estrogenized, and they cause cushion and lubrication. But what some people don't know is there's also, many forget that there's androgen, or don't know that there's androgen receptors there too. So with the transition and all these things that we were talking about physiologically happening in the ovary and interacting with brain hormones, there's less production of estrogen. And that can lead to decreased elasticity, cushioning, and lubrication, which can give people symptoms. Now, some women are like early in their perimenopause and they come to me and they're like, I am so dry and sex is painful. Some people are like 10 years out and they're like, oh, I noticed a little change. There's so much variability.
There is.
I'm sure you see this
There's
too.
a lot of variability. I will see 80-year-olds who are like, I'm fine. And I'll see 50-year-olds who are like, they look like they've been in menopause for, a long time, although that's just the way their tissues responded.
Right. So there's the way people feel. Like someone, I might, like you or I might look at someone and say, look, it looks pretty healthy. So you see things different when you examine people. The tissue looks paler, sometimes a little less elastic or drier. And then you can actually develop other vulvar skin conditions. But when you're talking about a traditional change, what people call genital urinary syndrome of menopause, or atrophic changes, is just not the greatest term, but it looks a certain way. Over time, it can become more apparent, and these can be more accentuated. I can have women who's look pretty good at 48, but feel very dry. And are uncomfortable. Or women who look pretty atrophic, but say to me, I just use some lubricant and I'm 75 or 80 and I'm comfortable. I always inquire a little further. If I say, are you having any dryness, are you uncomfortable? And they say no, I might say, well, especially if they come to me in this context, tell me a little bit more, but it might be that they've decided to only have outer course, right? That could be a great decision, or maybe it's a decision that if they knew they had other options, meaning they have manual and clitoral and vaginal and vulvar stimulation, but doesn't involve penile vaginal intercourse, for example, they might want it to be different. And so I always sometimes ask, or not push, but ask a little further sometimes. I may. I think those symptoms can vary. The exam may or may not correlate. Women also have symptoms unrelated. So these symptoms could be related or unrelated to sexual encounters of any type. And these, here it's easier to talk about that. We have more data in women with gender diversity, right? So I don't think we have time to get into the specifics how we understand this, but anybody who has organs that we've been discussing can have these symptoms related or unrelated to sex. I think that's the easiest way to think about it.
Yeah.
Because it's physiologic. And so sometimes it's like when I'm sitting, I'm itchy, I'm uncomfortable. Some women just have urinary symptoms because the urethra is hormonally sensitive. They might have frequency or urgency or just like it may interact with what's...
Or they may think they're getting UTIs all the time. Or they may be getting UTIs all the time.
Sometimes it interacts with this syndrome called overactive bladder, which I'm sure is another topic. Yeah. But the other thing I started to say, so that's estrogen, but the ovarian androgen production, which gets eventually metabolized into testosterone, also goes down by about half from the time that you're 18 to you're like 50. It's a gradual decline. It doesn't exactly correlate with menopause. And you make about half of your androgens from your ovary and the other half from your adrenal glands. So the good news is we still make substantial amounts. But there's sometimes that contributing piece because there are receptors on the genitalia for androgens too. And so like if some of the symptoms, well, you can treat that with either non-hormonal or hormonal treatments. Sometimes there are combinations that involve androgen topical therapies as well. But primarily it's estrogen. I think that's important.
Yeah.
So like getting into the management of that can be a whole discussion. But the short answer is you can lubricate. During sexual activity, you can use moisturizers. So those are different. Lubricants and moisturizers. And there's different types of that. Yep. There are several buckets of lubricants, several buckets of moisturizers. And then there's low-dose vaginal hormones that are used exclusively to improve the surfacing, right? And some of these other features. Yeah. And they're sort of considered later line if the other things don't work. But the same thing as we talked about with menopausal symptoms. If somebody has very severe symptoms and we see a lot of changes, we might start there in combination.
I would argue that generally they're very, very safe because they are so local. I mean, there is a little bit of systemic absorption, but for the most part, they're local. I use them very often, and probably because they've tried other things before they see me, but I use them very often as a first line.
I don't, like the hormone position statement from the Menopause Society that we referred to indirectly earlier says, there's one for this, right? Yeah. It's a different hormone statement. They say, like, start with the non-hormonal things, lubricants, moisturizers, regular sexual activity, keeping, you may even use dilators to stretch the tissue. I sometimes, as I said, like you do, I'm a consultant too, if I think in everyday gynecologic practice, it's good for people to follow an algorithm, but it's sometimes necessary if it's very severe to start and with these low dose hormones. Now, one thing that people are probably wondering, if you're using like systemic hormone therapy, so what we talk about like the hormone therapy for menopausal symptoms, that's called systemic. And generally we implied this earlier, originally it was all oral, and now we generally move more toward what's called transdermal, or it's also topical, but it's systemic. So that kind of hormone therapy comes in the form of patches, gels, and sprays. And there's also a ring you can actually put in that's systemic
vaginally,
and you can still use oral, and there's actually an oral, we skipped over this earlier, there's an oral combination that uses something that's not a progestin. It's something called a SERM, basically estrogen receptor modulator that protects the uterus by non-progestin methods, and it's a unique drug that's formulated for that purpose. But there are oral versions that have different safety profiles than the original WHI. So, but generally it's transdermal. The progestin is given orally, and in some, levonorgestrel or the Mirena IUD is used off-label by many gynecologists and so forth. Does that help these problems? And the answer is I have some patients who say, like, I'm not, ever since I've been doing this, I don't have dryness or discomfort. But there are others for whom it's just too far away. Like to get from your bloodstream to those very distal tissues. And sometimes people end up getting both treatments.
We often will do both. I mean, by the time they're seeing me, they've already usually they're seeing me either for overactive bladder, recurrent UTIs, or like significant discomfort that they think is UTIs. And so at that point, it's very reasonable to just do local if you don't want to do topical, or you haven't started topical systemic estrogen, or add it in addition.
Right. So women may come to at any point, like as we were mentioning, it could happen in the perimenopausal transition. More commonly, it's the relatively newly postmenopausal or even later postmenopausal women who are coming to me with just this problem where that's like the only thing I'm using. When it's like the collection of everything, you have to kind of piece it through.
Right.
And you can get some improvement, but generally you need topical for people. And it is progressive. The bad news is that it doesn't like menopausal hot flashes. It's different. It doesn't go away. These changes they come, they stay, and some women, they progress, others, they sort of just stay.
So till death do you part is what we tell patients when they start the topic of the local estrogen.
I've heard that, yes.
I just want to touch a little bit on, because people tend to ask about, so if they do have a hormonally active cancer or a history of like a breast cancer, are there ever indications where you can use hormones, or what do you just rely on sort of other measures?
I think it depends what the cancer story is and what type of hormones you're discussing. Mm-hmm. So if women, the easiest thing to answer is if someone's had a hormonally dependent breast cancer and they're having systemic vasomotor symptoms, there are very few oncologists who would endorse systemic hormone therapy. I think that's like a hard sell. And I usually advise women to discuss whatever we're thinking about with their oncologist, who may or may not agree, and then they still have choices to make, but it's good to at least get information from their oncologist. If somebody's had a non-hormonally dependent breast cancer, endometrial or uterine, then it's still very rarely done, because there's a lot of hesitation and concern about it. And there are other methods for dealing with, like we talked about, the hot flash vasomotor symptom complex, bone, cardiovascular risk, and that's where you bring out your other armamentarium generally. Yeah. If someone's under active treatment, when you're talking about local low-dose vaginal hormone therapy, it's generally a time to wait. Once their treatment is finished, even if they're on, say, a longer-term hormonal deprivation, like or hormonal controller, like an aromatase inhibitor or tamoxifen. Well, actually, aromatase inhibitors and tamoxifen are different. Let's say someone's on tamoxifen, or they had a non-hormonally dependent cancer and they're not on anything. There's good agreement that local low-dose, clearly well-dosed and well-explained to the patient to use it correctly is reasonable to do, and the guidelines recommend that they also talk to their oncologist. Yeah. When someone's on an aromatase inhibitor, it's a more considered dialogue, right? Yeah. It's not an absolute no. And there are breast oncologists who actually studied this. You do get a little blip in the levels, and the whole goal of an aromatase inhibitor is to obliterate all traces of estrogen from your system to protect the woman from recurrence of the cancer. That said, it's not an absolute no. It depends on the whole story. Yeah. So active cancer, no. Aromatase inhibitor, talk to your, any cancer, talk to your oncologist, but aromatase inhibitor, again, talk to your oncologist. If it's tamoxifen or you are not taking anything and had cancer, it's probably safe. It's reasonable and certainly considered becoming standard of care. Yeah. And I think there's the other place where I hear like a lot of anxiety and fears if there's someone had a family history. Yeah. Can't tell you how many times people say like, my mother had breast cancer, my sister had breast cancer, and they have like terrible dyspareunia, meaning pain during sexual activity, and bad atrophy, and they're afraid to use vaginal hormone. There's really no guidelines that suggest those women shouldn't do that. Nothing is 100% free lunch, right? Right. But the other thing to say to them is like, there's other things that are going to impact the likelihood that you're going to get breast cancer. One is that, I encourage people to get genetic testing, because a lot of people are there's now good genetic testing available, like the Invitae, whatever, to see. Now, that doesn't answer the whole question of whether they get breast cancer. And like, if they have high risk, 1 in 7 or 1 in 8 are going to get breast cancer. 1 in 9 people, you might get breast cancer. And can I promise you that I'll be able to like swear to you it wasn't from the vaginal hormones I gave you, even with your family history? No, but what we can tell about the attributable risk of doing this to your likelihood of getting breast cancer is low. The other thing is that like, people are very less mindful of other risk factors for getting breast cancer. Like this whole thing about alcohol, nobody likes this answer. I know. But I know what you're going to say. Like less than 1 drink a day or less is probably okay. Now it's like, none. I think everybody, including everybody I know, cringes when they hear this, is that no amount of alcohol. That's safer than any amount if you want to prevent, for the contributing factor to breast cancer. But does it mean you're like, everybody who drinks a glass of wine a day is going to get breast cancer? Of course not. But it's just not as like free lunch as we used to think it was. Yeah. And then diet, body weight, exercise, diet. Some of these things seem to also play roles in breast cancer risk. Absolutely. Let's talk about libido, because I think it is so common, right? There are so many factors, and I talk about this a lot on my channel, a lot on the podcast, like what affects desire. And there's many, many things that affect desire, but certainly there's changes during the transition of perimenopause and menopause that can truly affect desire. And so let's talk about those. So I think I mentioned a little while ago that there is a decline in the ovarian component of the androgen precursors, which are the things that eventually get broken down into testosterone or lead to testosterone production. And it's metabolic byproduct, what it gets broken down into, and that's another byproduct of testosterone. But let's just say testosterone for now. About half of what you always make, if you don't have your ovaries out, comes from your ovary, and the other half from your adrenal gland. And the curve, if you're watching the podcast, you can see this. If you hear it, I'm running my curve down it goes down gradually.
Yeah.
By the time when you start, if your highest peak is say 45, that's just a number, but keep that number in your head. When you're 18, by the time you're 40, for some women it's in the high, low 30s, high 20s, and by the late 30s to early 40s, and by the time you're 45 to 50, it can be running, 15 to 20, and then postmenopausal women, there's a lot of variable graphs that have been done in research. The scale goes down to 8, 10, 5. Some depends on the lab. So by the time people are hitting their 40s, they've sort of gone through the major slope in their curve. And then it kind of levels off around menopause. So for some women, the sensitivity of that decline in testosterone is the hormone of desire. It triggers receptors in the brain and in the genitals, both. I mentioned the genitals, vulvovaginal atrophy, but it's probably also responsible for sensitivity and sensation to touch. But it's the brain receptors primarily. They're receptors for testosterone in your brain, which trigger neurotransmitters, which lead down or trigger or turn on the pathways of desire in the brain. That's well understood in the research. And some women are sensitive to that change. And so there are opportunities to think about that. There's some in our field. There's off-label use of transdermal testosterone that's based on some evidence, but that's a discussion with a specialist or your gynecologist or a specialist in sexual medicine and a variety of fields who may understand how to think about that and use that.
And Dr. Parish was on the guidelines for testosterone in women, among many guidelines. So we are in the presence of an expert.
We don't have, thank you very much. These guidelines have been challenging, and we keep getting challenged on them because people don't like what they say. Because they want there to be more testosterone for women. So why isn't there a product for women? The FDA was quite strict about this in looking at the safety data and felt that the clinical trials that provided where products were tested with good efficacy, a patch and a gel. The gel actually was an efficacy issue, but the patch, which had the dose that was appropriate for getting women closer back to her earlier reproductive levels that I mentioned, like when you were 18, 19, 20, 30, and up to your 30s. The efficacy data was there, but the safety wasn't long-term enough. That said, it was shown to be generally safe except for some mild androgenic side effects, such as a little bit of acne and hair growth. The problem is that the FDA felt that safety data wasn't long enough. So when we use this off-label, we really are mindful of explaining to people what we do and don't know about longer-term safety and how important it is to use levels that are in the reproductive range and not higher. Yeah. So using male products and doing all that, you have to be extremely careful.
And that's why pellets aren't recommended, because they can cause super physiologic levels.
Right. So using lower doses of male pellets that are more produced and marketed to men. And so if men get 8, women get 1, that still may lead to excessive levels. There's no biologic rationale for being beyond the physiologic range of where you were when you were younger.
Right.
Just keep that in mind. There's no model for that. We don't give thyroid hormones super physiologic. We don't give anything else.
We don't give testosterone for men super physiologic.
Right. So libido can be managed by thinking about the role of testosterone, but there are many things that inform the libido of a midlife woman. So all of these other things we already talked about.
Yeah.
Her family life, her work, her sleep. Even if her menopausal symptoms aren't controlled, then women aren't going to feel much like sex.
Yeah.
So I think about that. Or if they're uncomfortable, the first thing I always do is, are they having bothersome menopausal symptoms if they're midlife? Are they uncomfortable? Maybe that will improve their interest and enthusiasm, because no one feels like having sex when they're sweating in one place and extremely dry and uncomfortable in the other.
And they're not sleeping and they're tired.
And then there's also some whole other category, which is women's mental health. So midlife is a time, there are several transitional times when mental health is more of an issue, like particularly mood and anxiety. So when people are in their younger years, there's vulnerable times in their teens and 20s, perimenopausal, later age. So sometimes the interaction between mood and libido and menopause, there might be another strategy, like treating depression, for example, or anxiety. And then finally, there are drugs, and I don't think people know about this. And they're both they're FDA approved and marketed for libido. There are 2 pharmaceuticals available. One is called Addy, which is the brand of the chemicals flubanserin. It's a daily drug. It acts on the brain neurotransmitters, the balance of serotonin and dopamine, and it works moderately well in in women in general, and in responders, it's been really quite helpful. You get about a 30% improvement over 20 to 30 over placebo, and there's a good placebo response. It's a great drug for improving, if it works for you, for improving sexual desire. And then there's an on-demand drug, which is less well known, and it's called Vyleesi. And it's a bremelanotide is the chemical, and it stimulates something called the melanocortin pathway in the brain, which basically turns on dopamine. And it's used as a very thin needle auto-injector on demand up to 4 times a month. And it improves intra-event responsiveness, desire, and potentially feeds forward to wanting to go forward. So these are very interesting options, and they're not well known. Mm-hmm. They are FDA approved for premenopausal women, but flibanserin's been studied in postmenopausal women and can be used off-label, especially in young perimenopausal and young postmenopausal women because of the ages of the women in the trials. So very important to make sure people know that there actually are pharmaceuticals that aren't hormonal, that if that's the proper answer after some of these other factors have been addressed, that these can be sought.
And they can be transformative. Right, if they work for you and everything else is sort of in line, they can be really helpful.
Both those pharmaceuticals, and I don't work for either company, no investment in this, have online telemedicine options where you can actually, you don't even need to know a provider. You can go right to their websites and have an interaction with an online telemedicine provider and learn about these meds. So something to know.
Really important what I want, because a lot of my audience is male, and I know the majority of the country is heterosexual relationships, right? So how can partners support their female partner who's going through perimenopause or menopause and having all these changes?
So I think one thing is learning and understanding what she might be experiencing, and asking her. Describe what you're experiencing. Like maybe someone wakes up in the morning and they snap because they're irritable because they haven't slept. Tell me what it was like, what you're going through. I know some male partners come to their female patient's appointment, their partner's appointment, and try to learn and understand how the symptoms are being explained and what the options or treatment options might be. Also learning with your partner about how to think about choices that may be challenging. Let's say you have a family history of breast cancer and you're scared to use hormones. Mm-hmm. Go to the appointment or read or learn and understand so you can help them, because these decisions sometimes cause some angst. At the most basic level, if your partner's telling you they're dry, get with the program and like suggest a lubricant yourself so that they don't have to say to you, hey, I'm sorry, I hear this all the time. Like, I don't want to tell him that I don't need to use lubricant because he's going to think he doesn't turn me on anymore. Or like if I push him away because I'm in pain, he's going to think I don't love him. So maybe you can say, hey, bring it up somehow. I don't want to script it for you, and if you hear there is some dryness or discomfort, be excited about trying something new. Yeah. Learn about lubricants. I don't know if you know about this study, but I was first author on a study called the Male Study. Mm-hmm. It was a survey that we did, basically surveying the male partners of women in menopause. It was an online survey. And we learned some really important things, which is men don't know that much, the male partners, and they want to know. Yeah. And they are generally supportive of understanding about these symptoms and being engaged in the treatment plan, so to speak, or how to make both their menopause life and their sexual life better by learning what they can do, right? And sometimes just a statement like, don't worry, we can use a lubricant. It doesn't offend me. Can go a million miles at the most basic level. I want to harp on that one because it came from something that we studied,
Yeah. No, it's really important. I try to give my male patients samples of lube when they leave the office. Like if we have a good enough rapport and we've talked about it, and they're telling me like, oh, we don't, like just bring it up. Say, hey, my doctor gave me these samples. You want to try it out? Like it makes it a little bit easier.
So if it's not like shame, like, oh my God, are you dry and you're hurting? Like, hey, let's try something new. I heard like, this makes sex more interesting, more comfortable, more pleasurable, especially as we approach midlife. And the other thing is joining. Like, generally people are around the same age. That isn't always true. But the we concept is much better than like, you're the one in menopause and now you're dry and you need this lubricant, or you're getting our bed sheets wet every night. You're waking me up every 20 minutes, tossing and turning, instead of like, you must be really exhausted and miserable. Let's find out what we can do to help you so we together can have a good night's sleep together. Yeah. So we can enjoy the night overnight together like we used to. Like that goes such a long way.
Yeah. And the good thing is there's so many things for every kind of person that we can do to help. I wanted to touch 2 more things. One is bioidentical hormones. So a lot of people use this terminology, and I think it's important for us to debunk the misinformation that we have bioidentical hormones that you can get, and you mentioned it earlier, from the pharmacy. You don't need to go to a special pharmacy to get a bioidentical hormone. Bioidentical means similar to your body. And any other thoughts you have on that?
So everything that's available in the entire universe is not, you don't take it out of their body and give it back to someone. It either comes from like the urine or a body part of an animal, and then it's synthesized and manufactured into something you can give back to a woman, or it's made in a lab. But the idea of bioidentical is being as close as possible to what you made naturally, so that when you integrate it or synthesize it, it has the most positive effect and the least negative benefit. And fortunately, when we're talking about the two that we have FDA-approved products, progestin and progestogens is the category, actually. And estrogens and estradiol is typically the bioidentical form. These are available in a number of formulations. We've mentioned some of them. All of them, I think, that are considered to be similar to what women make. And some of the compounding pharmacies and other places where these hormones are made and offered have variations on that. But they aren't, there's really never been any good data, at least that we're aware of, that these are better, safer, better integrated, lead to less adverse outcomes, and they're less predictably studied. So we don't know what's going to happen and how they're metabolized and how they might build up or affect end organ or cause harm.
Right.
And that's one of the issues and the problems. But if you want bioidentical, the good news is this is one of the areas, fortunately, where what's synthesized is quite close to what we are trying to return or replace.
Yes, you said that much better than me.
It's so hard because it's a concept that, I would love to like infuse something from the universe that's already like me.
Yeah.
But anything you get is made somewhere else.
Yeah, unless you're doing like PRP or something. You're like spitting yourself, right?
And you can't bank. Somebody asked me this once. Can you bank your own hormones?
Yeah, you can.
Like if they're so high when you're young.
Maybe someday, but not yet.
Not yet.
And then I got a couple questions about like rosehip oil and those sorts of primrose oil, soy, those sorts of things. Is there benefit to those? I know black cohosh has some good data, but I wasn't aware of the data on those other.
So black cohosh is the best product I would recommend because it's regulated and it's marketed and regulated by the German government, which does a very good job with herbal supplements as a herb. Mm-hmm. And it's marketed as remifenin. There are other versions of black cohosh, but again, no commercial interest in anything specific. But that seems to have some good data for controlling hot flashes. There are some other available supplements around that are touted to improve symptoms. I've never seen good trials in any others that have been consistently and reliably tested and shown to be helpful for menopausal symptoms. The use of soy. So there have been some food soy studies. The supplements are trickier, but the bottom line is eating the equivalent of like a quarter to a half of cake of tofu or a half a cup of shelled edamame every day gives you some modest improvement in hot flashes. So if estradiol takes you from 10 to 12 hot flashes a day down to 8 to 10. With soy, you probably get rid of a couple. You still have 6 or 8 or 10. So, and you have to eat that much. Like you literally have to eat that every day.
That's a lot.
Yeah, it's a fair amount, but not undoable,
And what about seeds? Like I've been hearing a lot about seed cycling.
I have not seen any good evidence or had seen my patients have any reliable or consistent responses to that. A lot of this is, it doesn't mean that anecdotally it helped someone that it doesn't help, but you're asking me like sort of scientific, medical.
Right.
It
may help you, but we don't have data.
And then the other issue is, are there any supplements for sexual function? So there is something called Rostella, which is a proprietary formula that basically works with the nitric oxide pathway. It's available through also, so I mentioned one of the other products. It's available through a specific company called Bonafide. It has a mixture of proprietary products, including things that work through nitric oxide and vasodilatory pathways, picogenol, there's a bunch of, you can look at the formula in the ingredients that may help with genital arousal and have a feedback on having a better event and wanting desire. That's another example. And there are a few small trials that are more like serial trials than randomized controlled trials, but where you look at a series of people is what that, there's a fancier name for that, but that's the idea. If people ask me what are natural things you can do for menopausal symptoms, there's the behavioral stuff. There may be a couple of herbal or supplements that help with hot, or one at least. For sexual function, libido, it's pretty much, there's some other supplements with L-arginine, and the one I mentioned, maybe. And then some of the pharmaceuticals, possible hormones. And also there's there's a whole collection of things we haven't talked about is the role of behavioral strategies for men when we're talking specific about sexual function. Then some work on things like mindfulness, mindfulness-based cognitive behavioral therapy, group training on improving or enhancing sexuality in the dyad or in the dynamics. And there's some very good books. For example, I love Lori Brado's book called Better Sex Through Mindfulness.
She's going to join us on the podcast later.
So that's another example. So those are all different things you can do that if you don't want to use hormone. I mean, there's a whole spectrum, in other words, for both menopausal and sexual symptoms. Great.
Well, thank you. We end with just a few sort of fun questions. What's something that you know now in your life that you wish you knew earlier?
Oh, boy. It doesn't have to result in the field.
No, anything you want to share.
I wish that I had known about cross-country skiing.
Really?
I know we were talking about how nice it is to live in a warm climate. Because I was just talking about this before I came. I'm a runner and I like to exercise. But as you get a little bit older, as you become midlife and so forth, and things start to ache and hurt. And only in the past couple of seasons has my husband, who loves to cross-country ski, got me to agree to go. And it's so low impact. And I love it. And so, I wish I had learned about that earlier because I like to be active and avoid the harm or the injury. Yeah. And we have to adapt as we get older. So it sort of fits the theme.
Right.
And I guess
never too late to try something new.
Yeah. I guess the other thing is I wish I had, it sounds really, really weird, but realized how much I would love having college-age children who are becoming young adults.
Really?
Yeah, because this is kind of, I have to stay thematic. As a midlife and beyond woman, I had a little of the sadness when my kids launched off to college. Yeah. They're both in college in different years. And, they seem to be engaging, one is on a term abroad we're going to visit, the other one competes as a high-level athlete. And we're following them around and doing things. And we interact with them very differently. And I thought I would really be sad losing that part of myself as a woman and as a mom. And I thought, oh my God, I spend too much time working and not enough time with my kids. And I guess the positive part is it's fun now. And so I didn't really miss anything. So,
that's great.
Midlife isn't sad.
That's really encouraging to hear as someone who has younger kids.
Yeah.
What is a non-negotiable you have to do every day?
Exercise.
Yeah.
I will be an hour late for a meeting, for a brunch, tell someone that I can't come because I have to find time to exercise. And it doesn't always have to be now I'm more careful, but some form of exercise. It's just it's my safe space. It's my haven.
Yeah.
And there's I either have to be really sick or it has to be a holiday where it just doesn't make sense.
Yeah.
For me to miss a day.
And what's something you wish would change about the world?
Oh my. Well, things I can
There's
say.
So many things you can say or you want to share in a large audience.
I think that some of the idealism that was non-controversial, that everybody sort of uniformly believed in, I wish it were more like that. Because now everybody's idea about idealism is so fractured. There are things that we think back on the history of at least this country. I live in the United States, where everybody kind of thought that's really great about this. And now there's so many different views on what makes something great.
Everyone's a contrarian almost.
Yeah.
Yeah. And last question is, what's a health hack you want to share or life hack?
I like sun.
Yeah, me too.
Sometimes I'll just be I have to walk outside. I go, okay, I'm going to stand here in the sun for 60 seconds, not look at my phone, not do anything else. It's going to make me feel so good. And it takes so much work to stop for 60 seconds. And so I don't know, maybe that's an example.
I think that's great. I did that today, in between the meeting. I went out and stood in the sun. Well, thank you so much. Let the audience know where they can find you.
So I live in New York City, or the New York City area. I live in the suburbs. I work for Weill Cornell Medical College. And you could find me that's the easiest thing, is to find me online through Weill Cornell Medical College. I think that's easier than thinking about the various social media outlets that I interact with. But that's the best place to find me.
Awesome. Well, thank you so much. It's been an honor having you.
Oh, wonderful. This conversation's been really stimulating and a lot of interesting ideas and a lot of fun. So thank you.
Yeah, thank you. Thank you guys so much for joining us today on the Rena Malik MD podcast. If you are enjoying this podcast, please be sure to check us out on YouTube or give us a rating or review on Apple Podcasts or Spotify. This allows our content to reach more and more individuals, and I'll appreciate it so much. If you want to learn more from me, make sure to follow my handle on other social media platforms, including Instagram, X, TikTok, and more. And as always, remember to take care of yourself because you are worth it.